All right, we're gonna get started. Thanks for joining, everyone. We have some more people coming in, but we'll get them going and get them caught up. Just so everyone's knowledge, this meeting is being recorded and will be posted online at the CSG Justice Center website after within a couple days after the meeting ends here. So thank you so far for everyone who's joined, and we'll get going for this session in our Ask the Expert series. The Virginia Department of Corrections Community Corrections Program joins us. It's a national criminal justice mental health learning site, and they'll be discussing their community corrections mental health program. The program's taken an innovative approach to addressing the mental health needs of people on state community supervision in the Commonwealth by embedding full-time mental health staff within their probation and parole districts. Presenters from the community mental health and wellness team will discuss how these positions were established, the role of the regional and district mental health clinicians in consultation with probation officers, and lessons learned since their implementation of the program in 2017. For note that this session of our Ask the Expert is sponsored by BJA and the Office of Justice Programs. For those not familiar, BJA's mission is to provide leadership and services in grant administration and criminal justice policy development to support state, local, and tribal justice strategies to achieve safer communities. BJA works with communities, governments, and nonprofit organizations to reduce crime, recidivism, and unnecessary confinement to promote a safe and fair criminal justice system. And the Council of State Governments Justice Center is hosting today's meeting. And for those not familiar, we're a national nonprofit, nonpartisan organization that combines the power of a membership association serving state officials in all three branches of the government with policy and research expertise to develop strategies that increase public safety and strengthen communities. Our goals here at the Justice Center is to break the cycle of incarceration, advance health, opportunity, and equity, and use data to improve safety and justice. If anyone has questions, I would prefer if we could save them to the end. You can either put them in the chat and I can ask them, or my bigger preference would be once our presenters are done speaking, you can unmute yourself, start your video if you would like, and ask the question, and we'll go from there. And with that, I'm going to kick it over to Patricia.
Okay, thank you, Steve. And good afternoon, everybody. Thank you very much for being here with us today. My name is Patricia Parham. I am the Mental Health Clinical Supervisor for Community Corrections in the Virginia Department of Corrections. I'm very pleased to be here with members of my staff in the DOC Mental Health and Wellness Department. I want to say very quickly about our name. Our chief, Dr. Denise Malone, for anyone out there who may know who she is, made a very purposeful decision a couple years ago to add wellness to our name, really for the benefit of inmates and probationers who still attach stigma to the notion of seeking help for mental health issues. And so we wanted to make an effort to clearly communicate that mental health is a part of overall wellness, and we're all about overall wellness. Also, a shout out to Steve and the rest of the CSG folks for the timeliness of having our team present as we close out Mental Health Awareness Month. So thanks for that. Okay, so I will get started. I'm actually going to start with a little bit of history of our program. Since 2017, we have had full-time mental health clinicians who work within our probation and parole district offices. Our program really reflects the recognition of the prevalence of mental disorders and substance use disorders in our corrections population, as well as the need for a continuum of care when people are released back to the community so that they can be successful. So the history part starts now. So prior to 2017, the mental health staff in community corrections consisted of only 5 people. That was a supervisor, that's myself, and 3 regional mental health clinicians for the Western, Central, and Eastern regions of Virginia, and those folks are with me today, and a senior mental health clinician who was assigned to our Community Corrections Alternative Program for women. And you're going to hear more about that later, but that's the Community Corrections Alternative Program, which we call CCAP, is also a component of our community corrections. And so we had, again, a total of 5 people in all of community corrections for mental health staff, in contrast to 150 plus for the mental health staff in our prisons. So the Virginia DOC, we have a research unit, and they publish recidivism studies every year. And around about, I came into this position in 2015, and around about that time, it might have been the previous year's report, was clearly showing and got a lot of attention, the increased risk of recidivism for folks who had some form of mental health impairment. So when I started, in purely a case of being in the right place at the right time, when I started in 2015, one of my first assignments was to assist with writing a budget proposal for our General Assembly to create new mental health positions in community corrections. And that's because they approve our budget. So I probably got spoiled that first time. We requested 22 positions to start with, and the General Assembly actually funded us for 20. So that was pretty good success. So we started rapidly hiring folks, starting in 2017 into those district mental health clinician positions. And I'm probably going to say DMHCs for the rest of this time. So getting that funding enabled us to implement what is kind of a unique approach to actually having mental health staff within the probation and parole districts. The primary objective for those new positions was to basically facilitate the continuity of care, increase the likelihood of success for our folks upon reentry who had mental health challenges. Excuse me. So currently, from 5 people, we currently now have a total of 25 district mental health clinician positions. And so each of my 3 regional staff, who you all will hear from, each supervise between 7 and 9 of those DMHCs. And we have a total of 25 DMHCs in the department now. We do have 43 probation and parole districts. So what that means is that most of the DMHCs actually are responsible for more than one district. And 4 of those DMHCs are also responsible for our 4 men's CCAP sites that I mentioned earlier. Only our CCAP site for women has full-time mental health staff. Let me see. So the way that I like to think about the DMHCs is we kind of serve as the in-house counsel for probation officers who have folks on their caseloads who have mental health issues. So the probation officers can make direct referrals to their DMHCs to assess the mental health needs of those probationers and then get them connected to treatment providers and resources in the community. They're really there to kind of, I would say, just kind of grease the wheels as far as getting people connected to services and resources. Our overall goal is to reduce as much as possible probation violations that are primarily related to mental health issues that would interfere with the probationer's ability to follow their conditions of probation. So if there is a treatment option, an intervention, or a program that would enable a probationer to be successful on supervision, we want to make those direct recommendations and direct them in that way, as far as getting them connected to services rather than have them return to jail for a violation. Another piece that I'll just mention briefly is that we, as an agency anyway, advocate strongly for peer support in our continuum of care. So we also have a contract with Mental Health America, Virginia, so that district mental health clinicians and POs can also make referrals for peer support services. Let me see. I believe that's kind of it. That's kind of the overview. I'm going to flip it over to Randy Horn to speak next, and I'll let him introduce himself. As I mentioned, so back in the day, actually going even farther back in the day, where we started as far as community mental health staff was with only one staff, and that was the mental health supervisor. I believe it was 2006, the mental health supervisor at that time decided he needed some help. So he created these regional mental health clinician positions. And Randy, who I always affectionately refer to as the OG of our crew, Randy was one of those original regional mental health clinicians that was hired. So I'm going to flip it over to him because he's got a very unique perspective of all of us, kind of the before and after DMHCs. So I'll turn it over to Randy.
Thank you, Dr. Parham. You know, it's always great to reach that point in life where you are referred to as the OG, the old whatever. So original, right? That's what the OG. Okay, all right. I accept that. I'm Randy Horn, and I'm the regional mental health clinician in the Western region with the Virginia Department of Corrections. And I've been in this position since about 2000, late 2006, so going on about 20 years. Been with the DOC for about 28 years, and with the state of Virginia for going on 32. So since I've been around for a while, Dr. Parham had asked me if I would talk a little bit about what it was like being a mental health clinician prior to the DMHCs starting in 2017. So thank you guys for listening to us, and thank you guys for giving us a platform to be able to tell a little bit about our story. So like I said, I started in the Department of Corrections back in the 90s. I worked in institutions for a while as a QMHP, and then made the switch over to probation and parole. I was actually a mental health PO for about a year and a half, and nowhere in my history would I ever have thought I would have been a PO. But circumstances just came about that was the case. So I just realized this the other day, Dr. Parham. I guess it was the first mental health PO. So I'm really old. So back in the day, that was a very new thing, and a lot of the other probationers found it very helpful to refer cases to me that had a mental health history. So after that, after being mental health PO for a very short stint, I became mental health specialist. We had 3 mental health specialist positions, and I think I was the first of those. And of those 3 mental health specialist positions, we have only one of those remaining to this day, and I'll tell you a little bit about that position also. But I think no discussion of what it was like prior to hiring DMHCs would be complete without telling you just a little bit, real quick, because I know we don't have a ton of time, but about the geography of Virginia. If you're not familiar with it, it's a pretty big state, a very long state. We have the 3 regions. You'll get to hear from the other regional mental health clinicians in the central and the east. But in the western region, where I am, that primarily starts, if you're at all familiar with Virginia, around Harrisonburg, James Madison University, that area, Lynchburg, Liberty College, and Danville, which is kind of on the border of Virginia and North Carolina. And so my area goes from that area all the way westward to the end of the state of Virginia. So it's Western Virginia, not to be confused with West Virginia, different state. But our region goes all the way to the end of Virginia at the west, where it meets Kentucky and Tennessee. So it gets very, very rural. Roanoke, which is where my office is, we have a regional office in the Roanoke area. Roanoke's kind of a moderate sized city. I guess it's the largest city west of Richmond, probably 300,000 people total, if you include the suburbs. So that's kind of the area that we're talking about. So back in the day, when it was just me as mental health clinician, and then the other 2 mental health clinicians, a typical day might be traveling 5 hours round trip in state vehicle. So it could be that you're in the state vehicle for 5 hours, you're doing face-to-face work in a probation office for another 4 or 5 or however long it takes hours. So some long days. But a lot of times it was doing work in the car as well, handling calls that way. 14 probation districts in the Western region, and 3 CCAPs, which replaced the original detention and diversion centers. So with all of those districts and CCAPs, it was a pretty busy time, to say the least. And people would a lot of times ask, how do you guys do this? Not just of me, but of Rick and the person that was in the East. Her name was Teresa, and then Rashida replaced her, but equally busy all the time. You know, how would you possibly do this? And my general answer at that point was always, it's just sort of putting out fires. Unfortunately, it's kind of the squeaky wheel gets the grease system, for lack of better words. But when there's only one basic mental health clinician and you're covering such a large region, you can imagine there's not a lot of time to deal with the mundane or routine sort of mental health issues, building relationships and that sort of thing. It's more getting to a district or getting to a CCAP, taking care of that fire for the day, and then moving on. And yeah, a really good example that I kind of hit on earlier was one time that I had to go all the way to Norton, which is, I didn't get to Norton very often, but it's about 3.5 hours from Roanoke. So that's about a 7-hour day, unless you want to stay overnight. So I get there, and I can't remember the details of the probationer, but it was very complex. There was a lot going on. The whole office was abuzz. So it ended up taking a long time. So I think it was about a 20-hour day by the time I finally got back to Roanoke. So I hope that kind of gives you an idea of just how we dealt with mostly only the most severe of cases. We also, back then, we did all the mental health training for probation and parole and the detention and diversion CCAP centers. So we have a basic mental health and suicide prevention training. It's about 4 hours, but everything was done in person. We didn't do a whole lot in virtually. Then it was all done in person. So that meant 2 or 3 trips to each district, 6 trips to each CCAP. It's 4 hours to Harrisonburg from Roanoke. So each of those trips was 4 hours. Teach a class that's about 4 hours. So I think you have a pretty good idea of how busy that was. So Dr. Parham had approached us with the idea that we were going to now be supervisors, and they were going to hire district mental health clinicians. And, of course, we've been doing things that the same way for so long. We were like, well, how is this going to play out? How is this going to work? But I think we're all super excited to find out that we were going to have other mental health clinicians to help us out. So just briefly, 2017 in the Western District, in the Western region, we hired 3 DMHCs. I think it was Wytheville, Lynchburg, and Stanton. So there was a little bit of a learning curve. Districts had to get used to having a clinician on site and learning what kind of cases would be appropriate to refer and that sort of thing. But it took off quickly. The districts that had a DMHC were so excited. The ones that did not have a DMHC were like, how come we don't have a DMHC? So we dealt with that for a while. Then we were able to hire some more DMHCs. We eventually had 6, 7, and now we have 8 plus 1, because we have 8 district mental health clinicians and 1 mental health specialist, which is that original mental health specialist position that I had way back in the day. And that position is in Roanoke. And the mental health the mental health specialist position that we have in Roanoke is very similar to what the other district mental health clinicians do. So it was exciting. So they could handle some of the severe cases that come up. I always say the biggest way for a DMHC to get a referral is you're sitting in your office and the PO comes down the hall and they stick their head in the door and they say, "I've got one for you." And there's someone in the lobby that's obviously in need of being seen. So they immediately started getting a lot of cases, but they were able to do much more than just the severe cases. And all the time that I was a mental health clinician, I thought, as we're putting out these fires here and there, I thought, what about the people that, a female probation or a female inmate gets out of prison, comes onto probation, and she's got a history of trauma, depression, substance use disorder. Where do these people get treatment? Who helps them? We were helping the people that were really in dire need, but there were a lot of people that probably weren't getting the attention and the case management that they needed. So it was really exciting. And for all of us who had been around for a long time, it would give you goosebumps because it was very exciting to see that people were really getting more of what they needed. So the DMHCs were able to do much more case management, medication issues, and I'm probably using a whole lot of my time, but just to give you a quick example, we have a district mental health clinician who was in Wytheville, and just recently she was telling me about a case that she was working. Now, the Western region is really huge, it's really large, but even the Wytheville area is very large, and there are sub-offices. So from one sub-office to the other sub-office is probably as big as some small states. So it's a long way. So she spent 2 days working one case, and every bit that she did was necessary. There was just nobody else to do it. She had to build a lot of relationships and collaborate a lot with entities, stakeholders in the community to get things done. But it was a very difficult case who may have fallen through the cracks in the past. So I would say relationships. Anybody ever asks me when we do interviews, they say, "What's the most important part of the job?" Or what's the most important quality of being a DMHC or an RMHC or just about anybody in life, really? And it's building relationships. So now these folks that are in the districts all the time could really get to know the probation officers and the chiefs and the deputy chiefs and all the stakeholders in their community. And you'll find that, especially in the Western region, a lot of people already know a lot of people in their community. They may know folks at the CSB, or they may know people that work at the hospital or in crisis services. So those relationships have proven to be very beneficial in a lot of circumstances. So the DMHCs have been able to connect in ways that I was just never really able to. I did my best. Sometimes it was a 6-hour trip to find someone in a community a few hours away. But now that those folks are embedded in those districts as part of the milieu of that office, it's made such a tremendous difference. Bridging the gap. So they were able to improve what we were already doing from releases from institutions and releases from jails. The Department of Corrections does a great job with the folks that are leaving institutions, but we don't have a whole lot of information sometimes on the people that are leaving from jails or the people that are coming directly from court. So now the DMHCs were in place and they were able to give a lot of service to those folks as well. That is really about all I had. The only other thing I was going to add was I can sit here and talk about DMHCs all day long and everything that we do, which is amazing, great stuff. But if you really want to see what we do in our programs, then give me a call or email us and come out and spend a few hours or spend the day with the DMHC in their area. Put your tennis shoes on because they really move. But that will give you a really good idea if you're thinking you want to move your agency in that direction, or you want to learn from some of the things that we've done, and we'd like to learn from you. So I think that is about all I have, Dr. Parham. And I believe Stephanie Beardsley is next, who is the Eastern Region mental health clinician.
Thank you, Randy. Well, Randy introduced me, so I feel like I don't need to introduce myself. So thank you so much, Randy. I'm going to talk a little bit more about what Randy was discussing, and that is community relationships and partnerships. One of the things that Randy hit on before, when there's only 3 clinicians covering an entire state, it's very hard sometimes to build and formulate the type of relationships that we need for ongoing care, for warm handoffs, for continuity of care, for making sure that returning citizens have all the services that they need in place, as well as being able to support our staff that work in probation offices. So I'm going to start with probation officers. Probation officers have high caseloads, as you're all aware. As Randy talked about, we moved to having mental health POs, and we found in a lot of instances having SMI cases on a couple of people's caseloads can be very overwhelming, can be very cumbersome. As a state, we've kind of moved to spreading out mental health cases across probation officers more equally instead of having mental health teams. Not to say that some districts don't, but really, I feel like the DMHCs have also been an important part of that process because they have been able to train staff who once may not have had the experience working with mental health probationers on what to look out for. What do we need to recognize? What is trauma? What is substance abuse? What are mental health symptoms? How can we support someone who's on supervision do the best that they can do while they're on supervision? What skills do they need? Who are the providers in the community that can provide those skills? So we really began when the DMHCs came was to build that foundation with our probation officers, kind of understanding our districts, building with our chiefs, learning what they felt were the needs to make probationers successful. Because as Randy said, not only are we looking at vast geographic areas in Virginia, even within our 3 regions, we are looking at vast differences in resources and funding and money, all within our own area. So what we may do in one district, we may not be doing in another district, even within our own regions, just based off the resources available. So we began building those relationships, hearing what our district said they needed, how they felt probationers could be more successful in supervision, how we could help them reduce recidivism rates for those districts. And then we started building relationships. So we heard we need stronger relationships with our community service boards or our CSB. There are localities, mental health providers, and they may have PAC teams, they may have ACT teams, they may have crisis stabilization. And how could we tap into utilizing some of those resources for our probationers to prevent having to do violations? Because one of the things that were really important in looking at reducing recidivism is looking at what resources are available for public safety besides arrest. What can we do? What interventions can we put in place before we arrest an individual who's on supervision? So we started building those relationships. We looked at hospitals. We looked at our state hospitals. How can we form a relationship with our Department of Behavioral Health? What resources do they have? How can we use any of those resources? How can we help each other? We worked with our community providers, our private hospitals, working with our psych units on those, trying to help coordinate services upon release so individuals weren't going in for a hospitalization and coming back out essentially the same way they were when they went in. If they were missing appointments for medication, how could we help connect that service? If we are having housing issues, how can we build upon finding more permanent living situations? Because as you know, if basic needs aren't met for someone who's on supervision, then they have a less likelihood of being successful or being able to complete their supervision. Then we looked at, okay, well, obviously we can't bombard our CSBs with everyone who needs services. Randy talked about our individuals who aren't our SMIs. He talked about the female released who might have a history of trauma. What can we do for those people? Because they're not getting into our CSB. Well, then we need to work to form relationships with other community providers, mental health skill builders, individual therapists. How can we connect those individuals who may not be our highest level of care to services to help with substance use needs, trauma needs? And we built those types of relationships. So really for me, when I say it all the time, they're like, what are you in? I'm like, oh, I'm in customer service. We really are about building those relationships, getting our partners all to the table, finding out what they need, what we need, and how we can work together. One of the things I think all three of us, Jay would agree, but Jay's in a little bit different position now, is that, sometimes we talk about cases that aren't always DOC cases because you want your provider to know that they can staff things or talk to you about things that aren't just for you, because then they feel that you're bought in, you're engaged in the process, you really want to make this process work. Well, a big thing for Virginia Department of Corrections is that most of our inmates who become probationers don't serve their time in our state prison system. Majority of folks who end up on supervision come to us from supervision either straight from court. So they'll go through the legal process. They have spent enough time in jail to satisfy sentencing guidelines, and then they go to court and it's determined that they're going to be put on supervision. So here they come. They come in the district. We know nothing about them. We have no information. So, we have to work where we're at. The other part is from jail. A lot of folks who do serve time, after all of their stuff happens with their credit for time served, while they're waiting to make it into the court proceedings, by the time they get done, they have less than 15 months to serve. Generally, folks who have 15 months or less are not brought into the department to serve their time. They finish that time in their local or regional jail. They are not brought into the department. So again, we don't receive the same level of information that we would receive if we had someone coming from us from a state prison. So we really began working on building relationships with our jails. A lot of our jails have mental health clinicians in them, either ones that they've hired themselves through nursing or contract. They also have CSBs at times in their jails doing discharge planning or reentry. So we felt like that was a really good resource for us to start talking with for our probationers who have become inmates in their local or regional jails on, again, where can we help fill the gaps? Joe has come in and out of this jail on a violation or petty offenses, 3 or 4 times, and we're just, as soon as they come out, they're going back in. How can we work with you? What do you think Joe needs when he's there or when he comes out to kind of break the cycle? So we really have worked hard to work with those local and regional jails because, again, they're not under the Department of Corrections. So all of this is about healthy relationships. This is all about communication. This is about building a partnership together because we don't control, we have no say in how they run their house. So if we want to have a successful relationship, you have to put the work in. And our DMHC spend a lot of time building those relationships and talking about needs and cost. If we build this relationship and we work on this, the cost benefit is that hopefully they won't be revolving through your jail as much as they were. Hopefully we'll see a reduction, in their need for reincarceration. So we really have focused on building relationships there as well. I feel like I hit all the relationships. Dr. Parham, is there any other one I didn't hit?
I think the only thing I would just add, Stephanie, and this isn't kind of community in our engagement, but one of the things that has been a really nice surprise, I guess I hadn't thought about it so much when we were creating the positions, is our consultation even with our counterparts and our mental health staff in the prisons. And so we have really been able to do some really good things as far as release planning, because our DMHCs and our RMHCs not just are resources for their probation and parole districts, but also for our staff in the facilities. And I can say I came from the prison side of the DOC, and I can tell you that, well, first of all, coming to community corrections is a really steep learning curve that I'm still on. But when I worked in the prison, I really had no idea of any of stuff I knew we had a thing called community corrections, but my colleague was a supervisor over there. So, yeah, so I just really think that it has been a mutually beneficial relationship to learn and have better understanding of what the other side of the house does. And I think that has been a really big benefit. One of the things our chief, Dr. Malone, put into place is that she required folks, so if you worked in the prison, you were required to go and visit at least one probation and parole district. And if you were on the PNP side and community, then you were required to go and visit a prison. And I really just, if I could wave a magic wand to just have huge impact, I would give everybody the experience of working on both sides, because I feel like that really, I can say personally from experience, it's really been tremendous.
Yeah, I would just add too, because when you said that, that reminded me about the relationships that the DMHCs have with the other RMHCs and the other DMHCs themselves, not even within their own region, but across their regions. Because everyone has a challenging case, everyone has a case they need a staffer talk about, but the relationships, even amongst themselves, that they have built to say, I've got this case, I've done X, Y, and Z, and now I need you to tell me A, B, and C because I don't know what else to do. The relationships they have also built amongst themselves because they have built such strong community partnerships that they've been able to staff cases with each other and think about resources that another person, because of their locality or where they're located, may not have thought about, and access a different vantage point, a different place to go. They're constantly saying, hey, send me this person. I've got this place. I think we can manage them here. So just even the teamwork across regions, within regions, has just been, I think, a very different process, because like Rainey said before, I mean, generally when there were 3 people, when I first took this position, it was only 3 people. He's right. It was triage. You're putting out the fire you can put out. And sure, sometimes you would call your counterpart, but most of the time you weren't looking at some of the case management things that really cause change, that really promote change, positive change, warm handoff. We couldn't focus as much on those types of things. We had to focus on what is happening in this minute and how do we stop what it is in the most effective way. Because I mean, I can't tell you how many times I pulled over in rest stops. Hold on a second. Let me get my computer open. Let me open this. Let me read something. Have your phone going one way, your computer going the other way. So really having the ability to provide more meaningful services that really have an impact in a beneficial way, helping people be more productive members of society, has really, really been a benefit from these relationships and what the DMHCs have done across the state. So that's all I have. So I would like to introduce Wayne. So Wayne is going to talk a little bit. For a minute, I thought it was Jay, but we said Wayne. So Wayne Reed is the Central Region RMHC.
Thank you, Stephanie. Yeah, and I'm the youngest one here, not age-wise, but in the position. I just came into this position a little bit less than 2 years ago. But before that, I was in the institutions for a little bit over 20 years. And so the perspective I wanted to bring was a little bit about what Dr. Perrin was just mentioning. What does it look like when you're working in a prison, people are being released, and you collaborate with the DMHC on difficult cases? So I'm going to do a little bit of storytelling today. So hopefully that'll go over okay. So as I said, I worked in a maximum security women's prison for the majority of the last 20 years. I was the mental health director there. And it was a pretty big deal. I mean, we had a pretty big team. We had 8 therapists. It was me, 8 therapists, 4 different psychiatrists that worked varying numbers of hours, a psychiatric technician. We had some inmate workers that we called mental health assistants that also worked with us. We did outpatient services with general population, so just like outpatient therapy and medication management. We had an inpatient unit as well, was the only inpatient unit for women in the state of Virginia in the DOC. And so we were able to do involuntary commitments there. We did a lot of intensive treatment there. And then we had sort of a middle of the road kind of setup where we had residential mental health units, so sheltered residential units. And so we had this array of services that that we used to try to, our goal was always to keep people in the least restrictive environment, but also the most appropriate environment based on their functioning. And so what we were used to doing was someone might be in general population, for example, and over a period of time, they may decompensate for whatever reason. And we might have to bring them into the mental health unit and work with them in the mental health unit, have treatment plans and work with them closely and work on coping skills and distress tolerance, or maybe learning how to deal with psychotic symptoms or things like that. Or we might have to go to the route where we hospitalized somebody and treated them over their objection until they were able to be more stable. And what our goal was how can we get them back to the next lowest level of restriction? So we had a lot of people that we would sort of bounce in between and kind of back and forth and depending on how people functioned. And I think we did a pretty good job of that. But one of the most challenging aspects was, especially with seriously mentally ill people, was when they were leaving and releasing and going to the community. There were two things that seemed to pop up to make things problematic, and we actually call them problematic releases because of that. And so one of the things was that many people didn't have a good home plan to go to. In the Department of Corrections, we have case management counselors in the institutions, and one of their jobs is to sort of develop a release plan for the person. So they start working on that, a long time before the person releases. And so many people might go to their families, or they might go to friends or something like that. A lot of the SMI folks we had just didn't have real solid home plans to go to. Either their family wasn't around, they didn't have a lot of friends, or maybe the home plan wasn't approved by the probation and parole office because of some things that were going on in the home. And so, what we really didn't want to have happen was to release people directly from a mental health unit, especially, or even if they were living in a general population, if they had an SMI, we didn't want to release them homeless. But that sometimes was the case. And then we also had, Stephanie mentioned this earlier, that there's a wide variability in terms of services that are available in certain locations. So one district or one jurisdiction might have really good mental health services available and a lot of them, and the neighboring one right beside that might not have much at all. And so those were the two things that made things problematic, is getting people hooked up with services when they left and getting a good solid home plan. So I got a couple examples, and I'm going to go through them real quick. This is the storytelling part, by the way. We'll call the first example, we'll say that her name is Miss Parrish. She was in her late 20s. She had a history of severe trauma, had some dissociative episodes that would sometimes occur that were very challenging to manage, history of substance abuse, self-injury, and several suicide attempts. So when Miss Parrish came to us, she was transferred to us from a medium security facility, and she was transferred on safety precautions because she had, I think she had cut her wrist or had cut her neck or something had happened where they weren't able to manage her there, and they sent her to us because we got all the precautions people. So that wasn't uncommon for us to have a transfer in like that. After going around with her for 2 or 3 rounds where we would release her to general population, she would cut again, or she would threaten again, she would go back on precautions. We realized, well, let's go ahead and move her into the mental health unit and start working with her a little more intensively here. And so we did that and had pretty good success. After just a little bit less than a year, she was able to move back to general population. She kept her therapist and had regular appointments with her therapist in general population and did pretty well. No more incidences of threatening self-harm, no more self-harm that we knew of. So things looked pretty good, and we felt pretty good about it. Well, about 3 or 4 months before her release, we recognized, the counselor told us, look, we don't really have a home plan for her. Like, she doesn't have any family, she doesn't have any friends. She says she just wants to go out there and be homeless. We thought, well, that's not really what we want to do. So the counselor was able to secure a bed for her at a CRP, which is a community residential placement that we have here in Virginia. They were able to secure a bed for her. And so she didn't want to go. I've heard things about that place. I'm not going there. They have too many rules. The curfew I don't like. You have to go to AA meetings, and I don't want to do that. And I'm afraid I'm going to get stuck there. I'm afraid I'm never going to leave. I feel like I'm going to get stuck there and never get out of there. I need to get out there and work. And so no matter how much we talk to her about, well, look, this is really a good option for you. You can actually live there for free. You can get a job. You can start working. You can save some money. You know, the meetings are a good thing. She really didn't want to hear it. And she also didn't want to go to mental health treatment once she got out because she didn't trust mental health. She told us, you know, you guys are the only people I've ever been able to talk to. You're the only ones that have ever helped me, and I'm good. I'm just gonna, you know, I'm just gonna rough it. So I called the DMHC in the area where she was going. His name was Rick. And so I called him up and I said, Rick, look, here's what we got. And so I talked about it with him. I gave him the story. And I didn't know, you know, if he could do anything about it or if he could help us at all, but I just really didn't know what to do. So he goes, well, Wayne, you want me to come out there and talk to her? And I thought, sure, Rick, that'd be great. Just come on out and talk to her. You know, I'm just going to give it to you. You figure it out. So I wasn't really sure what was going to happen, but he came out probably a couple of weeks later, and we had an appointment in my office with me and Miss Parrish and Rick. And I just kind of sat back and didn't say a lot because I figured I'd said enough. And so Rick just came in and really did a great job with her. He just said, well, he introduced himself. He said, just tell me what some of your concerns are about going to this CRP and about receiving treatment. You know, Mr. Reed told me about that. Just let's talk about it. So she, you know, talked a lot. He listened. He then, once they were done talking, he says, well, I want to show you something. And he pulls out this brochure from a CRP, the one that she was going to go to, and he handed it to her. And he said, I want you to open that up and I want you to read along with me while I read it to you. And so he opened up a copy himself and he read the whole brochure to her. And she sat there and she read along, and you could see her kind of changing. Her demeanor was shifting as he was reading. And so when they got to the end of it, he says, you know, what do you think? And she says, well, I'm a little, you know, I forgot exactly how she put it, but you could tell she was a little more open to it, but she wasn't really sold yet. So he says to me, can you open up your computer and go to this website? And so I went to the website for the CRP, and he said, hit the testimonial button. And so there's a little button in the corner that said testimonials. And I spun the screen around and played for her a testimonial from someone who had been through that CRP, who had been in prison before. And at the end of it, she was crying. And she said, I'll go. And I get choked up thinking about it because it really was pretty impressive. So he says, okay, so now let's talk about treatment. And he said, I realize you don't trust people. What would it be like if for the first 6 or 8 weeks that you're out, I met with you every so often? I can do that. I can meet with you. We can talk about things. I can help support you in what you're going through. And I can get you hooked up with someone in the community, that a provider that has experience with the issues that you need to have addressed. It's just something we can work for. You don't have to just go out and start with someone else right away. What about that? And she said, I think that sounds like a good idea. So that was really eye-opening for me because, you know, I didn't have that connection. I didn't even know there was a brochure. I didn't know there was a website. I didn't know these things. I didn't know that he could meet with her. And even if he did, I don't know that I would have said, well, you know, this, you'll have this arrangement. Being able to collaborate with him, have him come to the site, meet her before she gets out, and just talk about what the possibilities were made a huge difference. And so I was really grateful for that. That's story number one. Story number two is there was another woman, we'll call her Miss Harvey. She was in her late 40s, a long history of schizoaffective disorder. Excuse me one second. Okay. A long history of schizoaffective disorder. She had traumatic brain injury and a history of cocaine abuse. This was her 3rd time at Fleabana. Every time she got out, within a couple of weeks, she was back in jail and back at Fleabana. Fleabana is the prison where I was working, by the way. So she bounced back and forth between our inpatient unit and our residential unit. At her best, she was a handful. She was very impulsive. She got easily frustrated, was very quick to anger. She stole from all the people that she lived with, she'd walk by the table and see someone's laundry and take it and say, it's mine. And, you know, we really never could figure out if she really thought it was hers or if she was actually just stealing it. But she required a lot of prompting to do things and to sort of meet the expectations of living on the unit because of her memory and just didn't have a lot of motivation. And this is when she was at her best. When she was at her worst, she was paranoid. She would have command hallucinations. She would stop eating for days at a time. She wouldn't shower. We would usually have to commit her to get her back on medicine because she would stop taking medicine. And so we knew that she was leaving again in a few months. And we thought, you know, going back to home to her mother, her elderly mother, isn't going to work because that's what's happened the last couple of times. So that's not a good plan. Doesn't really have anywhere else to go. We started looking at assisted living facilities, but we thought, well, can they really manage her? She's really high maintenance. Someone's going to have to follow her around. She would wander off, and she was just really a handful to manage. And at the same time, we knew that if we just couldn't just let her go. We thought, well, maybe we can commit her to the state hospital. Maybe she'll be committable at that time. But, you know, if she wasn't committable, then what do we do? So I called the DMHC in the area where she was going, named Desiree, who actually works under me now, but at the time she didn't. And we told her about it. We said, this is what we have going on. What can we do? And she said, well, how about this? How about if I set up a call between us and you and the CSB? We'll get the CSB involved where she's going, and we'll just see, you know, if we can brainstorm together and come up with a plan on what we can do. So that's what happened. We had a call a couple of weeks later, probably. She had invited someone from the Community Service Board, which is the CSB, and we were all on the call together. And so we laid out our concerns. Here's what we're concerned about. Here's kind of the symptoms that she has and the problems that we experience with her. And we talked about two different options. One was, okay, look, when that month gets here, when she gets released, we don't know if she's going to be stable or not. If she's not stable, we're probably going to have to go ahead and try for a civil commitment at the state hospital. But if she is stable, then she's going to be coming to you. What kind of options do we have in terms of housing, wraparound services, things like that? We were lucky because they told us that they had their own house that they managed, and that I think it held like 8 or maybe 9 people, and they promised us that we will hold a bed for her. This wouldn't have happened. I mean, I could have called the CSB all day long and talked to a lot of different people. I don't think I would have found this information out, but because this meeting was set up, it happened. And then we started talking about, well, what happens if she goes to the hospital? You know, will she get lost in the shuffle? Will that bed still be there if she ends up going to the hospital? And what we found out was the person that was on the call with us was a liaison with State Hospital for that CSB. And so they said, look, you know, we have a lot of flexibility to kind of make things happen. You know, she's able to get day passes to leave the hospital once she's stable enough to get a day pass and come to the house and stay there for the day, or maybe stay for a couple of days through the weekend. And she can go back and forth, and we can get used to her. She can get used to us. It's a really good way to kind of transition her into the community from the state hospital. And so, again, you know, we left this meeting thinking, you know, wow, this is really good stuff. Like, we don't know this stuff exists. We had no way of knowing this. I think we could we have found out? Maybe, and I'm not blowing our own horn, but look, we're really busy inside a prison. You know, there's a lot going on. And so making these connections in the community with 43 different districts and all these different mental health providers, it's really nice having somebody out there that is familiar with the resources in the area, has relationships with those resources, and they really appreciate the challenges people face when they first get out of prison. So those are my stories. I remained in the prison for a while after that. I remember thinking, man, I got to get out of this prison. I need to get into the community and do some of this work, man, because this is great. You know, we had a lot of success in the prison, but we knew that as soon as people got out, they had a whole different set of challenges, and we never really knew what happened to people. So when this job came open, I think I applied within about 10 minutes. I was applying for the job, and was very fortunate to have it and work with a really good team here. Very proud of the work we're doing. I'm still learning and still really enjoying the work. And that's it. That's all I got. So I'm going to let Jay Flippin introduce himself, but I'll pass it on to Jay.
All right, thanks, Wayne. My name is Jay Flippin. I'm the Senior Mental Health Clinician at the Chesterfield Women's Community Corrections Alternative Program, or the CCAP here. So starting to talk about what that is, just to give you some background on that, it is a cognitive community-based program that is used as an alternative to incarceration when it comes to treatment or sanctions. So what happens with that is people will be referred to CCAP in their court district, in their systems. They will be screened by their probation officers. We have a referral unit that then kind of determines if those people meet criteria, whether those be they don't have pending legal matters, they meet mental health criteria, they meet medical criteria to be here. And so once all that is determined, people are then assigned to come and complete our program as an alternate to prison. Once they arrive here, they are screened for risks and needs to put together a treatment plan. And services, things we tend to offer here are substance use disorder treatment, GED and other educational opportunities, workforce development, vocational training, and at our a chance to work. At some point, the way our system works is once you complete your core treatment, then you have the opportunity to go out in the community and work, earn a wage, save some money while you're in our program. And at our women's site, which I'll talk more about what I do at the end, we also offer specific mental health treatment groups, classes, things like that. So once all those things are decided, people in our CCAPs, we have 4 male sites. We have the 1 site for the women. The role of the DMHCs with the CCAPs is if a CCAP falls in their probation district, they will then provide mental health coverage for that CCAP. They're not full-time at that CCAP. It's just one more part of their job. It's like having a 2nd or 3rd district in some cases that they have to cover. So it's just a lot more on them to cover that. Their role in those things is essentially referral based for the most part. It's if someone comes in who shows up with elevated scores on a mental health screener, they will be notified. If staff is observing some concerning behaviors, mental health symptoms, instability, they will contact the DMHC, who can then come in, do assessments, provide short-term interventions, provide psychiatric referrals. They can provide management recommendations to staff. They can attend multidisciplinary treatment team meetings to kind of educate to, hey, you can kind of expect this, or these are some ways I think we can reinforce this to help manage this person. Or even eventually, if needed, make recommendations on the suitability of that person to remain in the program if they are becoming unstable. Let's see. One of the other big things they do then is, as people are winding down their time in CCAPs, is same type of thing, is working to connect them to resources and services as they're headed back out into the community. So as you're getting ready to go home, what's your home plan? Here's what's available in that area. Here's some resources that you can use, who can we connect you with, make sure everything's lined up for those who have mental health needs. Let's see. The men's sites work in typically they have an intake site, and they have primarily treatment sites, and then they have primarily work sites. So you go through, you do your core treatment, then you move on to a work site. Women's site's different. We all do it in the 1 site. So you come in here, you do your intake here, you do your core programming here, and then you eventually go out to work while you're here. My role is a little bit different. I'm not technically a DMHC, but I do cover the CCAP. So it's really kind of unique in all of our community corrections here is I do the thing that looks the most like an institution. So a lot of my job is direct treatment provision. I run a lot of groups. Right now, I think I'm running 10 groups a week, and I focus on things like trauma treatment. We have a couple different trauma offerings to address that need. As a gender responsive need in our women is they tend to have a lot of traumatic experiences, a lot of symptoms as a result of those traumatic experiences. So I focus on that as a treatment goal. I offer DBT skills-based programming, working on emotional regulation, increasing mindfulness, things like that. And I also work on solution-focused interventions, those kind of short-term interventions, and bringing in solution-focused thinking into their purview. Okay. My job isn't as much referral-based because I'm here all the time. I get to kind of keep my hand on the pulse a little bit. So people are able to come directly to me. I'm able to keep an eye on people. I've got them in classes. I can see when they're kind of struggling or going through something, and I can be kind of more direct with that. So my job being the full-time one, I get to be more engaged in that aspect on a daily basis. Whereas our DMHCs have to come in as a kind of part and rely on referrals and kind of stay connected and management and those types of services. So that is kind of part of their job amongst all the other things they do. And I will say this too, as you know, things have gone, our DMHCs, CCAPs are demanding more and more of them because we are having more need even in our mail sites for mental health services. So it is becoming a larger and part of their job, and they do a great job at that coverage. So I'm going to be the short one. It's 3 o'clock. I'm going to wrap it up because it is relatively a small part of what community correction does, but an important one. So thank you. And I think I'm going to kick it back to Dr. Parent.
Thank you, Jay. Yeah, you're right. It's a very important part of what we do in community corrections. And I'm glad you mentioned that so historically, this happened before I came into the position, largely based on, knowledge about the incidents of trauma for women, criminal justice involved women. That was when the decision was made that they should have a full-time mental health clinician at the Chesterfield Women's CCAP. So Jay pretty much has the most unique position, I think, in the DOC. There's no other CCAP that has a full-time mental health clinician. Having said that, like he mentioned, we the superintendents at the men's CCAPs, more than one of them, actually I'd say all of them, have expressed an interest in having their own DMHC for the CCAP. So we really hope that we'll be able to expand, not just for the CCAP, but for the districts as well. It's really nice when the biggest complaint that I get from probation chiefs is that they want their own DMHC. They do not want to share. So we're working on that. I think, what else did I want? I just want to say a couple other things. I know that it's very easy to slip into using acronyms. So in the chat, I defined a couple of acronyms that we were throwing around just for y'all's benefit. And I will close us out just by saying thanks to everybody who took time for this today. I know we're not going to have a ton of time left for questions, but I'm excited to be a learning site because we'll have the opportunity beyond today for any folks who want to get in contact with us, to find out more about what we do, to come and do site visits. We will welcome that, and we're pretty excited about that opportunity. I think that's it. I will just say, as I always say at the end of most things, is that this has been a very humbling professional experience to me, because for two reasons. One is that the probation and parole districts, they were rolling along for years and years and years before they had any mental health staff support. And so to know that and realize how important it is, it's on us to demonstrate how we can be useful to them. I also have so much respect for probation officers too, that I did not even realize when I was on the prison side, just because they have to wear so many hats. And I think that we're all really proud to help them with this load when it comes to the mental health folks on their caseloads. The other humbling thing for me is that I have never worked in community like all of my staff do. So I feel very fortunate. I always say that I feel like the luckiest supervisor in the DOC to have such an amazing team. Yeah, and this has just been a wonderful experience. So thank you all.
Thank you guys very much. I'm gonna just open it up actually for questions. If anyone has any questions right now, now would be the time. You can just unmute yourself, turn your video on, whatever makes you happy. Or just unmute yourself and go for it.
Can I ask you one thing, Steve?
Absolutely.
Because we know we had already gotten kind of a couple specific questions, and I know we have the website, but can we just can I put our email addresses in the chat also?
That would be very much appreciated. Yep.
Good deal. It all follows the same formula. It's our first name, last name, and then at vadoc.virginia.gov. So I'll just put that in.
And while we wait there, I'm actually gonna ask one that I have here and whoever wants to jump on it can. But there's a question about the ratio of clinicians to individuals who are on parole or probation. I realize it's different for different regions, but anybody want to tackle that as an example?
Actually, I just happen to have to do that for the Eastern region. So I can generally say our numbers. I think they'll probably be pretty similar across for Wayne and Randy's folks too. On general, the average for us per district. So one of the things that we didn't talk about is that everyone who comes in to probation is referred to the clinician so that we can gauge whether they're what the needs are or not. And then we code them, which is what we do, mental health coding on no need all the way up to significant need. So you could fall anywhere on that continuum of the level of assistance you may need from a DMHC. So I just kind of want to start by sharing that. But the average for, depending on the size of your district and the how many you have in your district, ranges from 500 to 1,500 that have mental health needs. So again, that's because most of them have more than one district, or they may have a district and a CCAP facility, but that's their average. Now, again, they're not providing ongoing service to everyone every day on that list, because a lot of them are what we call a CMH1, which means they are on medication, they're in treatment, they're responding well to their supervision guidelines, they've either got employed or they're on disability. So everything is going well. So they can check in with us as needed up to our greatest need, but that just gives you the general idea.
Thanks, Stephanie. I'm glad you had to look that up recently. Because I definitely don't know it by region. I know that overall, we're somewhere in the neighborhood of around 60,000 probationers total. And we usually use as just kind of an estimate, a benchmark. We keep, each year we look at the percentage of inmates in our prisons that have mental health codes as being kind of our estimate of the percentage of folks who are going to require some form of mental health services. And I think that percentage is now up to about 35% most recently. So it's a big number of people to our 25 DMHCs overall.
Thanks, guys. Anybody else, feel free to unmute yourself and just fire away. All right, with none coming in, I'm just gonna leave it there at that. As you've spoken to, our group here is a national criminal justice mental health learning site, so there are not gonna be any shortage of questions for them in the near future for sure. And this recording is, or this meeting was recorded, so it'll be available to everybody online on the site that you registered at previously. So feel free to go there and look at the recording then afterwards. And that site also is going to have access to our learning sites website, which just rolled out. So you'll be able to access all these fine people through that site as well. But if there's no other comments or questions, I'm gonna wrap it up. So I'll leave it to you guys if you have anything else you want to follow up with.
Just thanks for your time. And I also want to say thank you very much to Randy, Stephanie, Wayne, and Jay. I know some folks who I will not name were not super excited about doing this, but I think you all rocked it. And thank you so much.
I also want to thank you guys for joining us too and getting on. That's a great presentation. I'm looking forward to sharing it. I already have several emails of asking if I could get a copy of it to give to their staff. So I will get back to all these emails shortly as I can. So thank you guys again, and everybody enjoy the rest of your day and take care of yourselves.
You too.